Hi everyone, my name's Nathan from the European Pain Federation, and I'm joined by Professor Michele Sterling, and they're going to give us some more information about their plenary session at this year's EFIC 2023 Congress, which is being held in Budapest in September. Welcome, Michele.
Hi there, Nathan.
Hi.
Glad to be here today.
Fantastic, fantastic. So do you just want to start us off by introducing yourself and giving us a little bit more information about your session that you'll be delivering?
Sure. So, as you mentioned, I'm Professor Michele Sterling. I'm a musculoskeletal physiotherapist by background, and I worked clinically for around 20 years before deciding to embark on a research career, and I completed my PhD in 2003. And from that time, I've really had a full-time research career. At the moment, I direct a research centre at the University of Queensland, which its main focus is on improving recovery for people following road traffic injury. So what I'm talking about at the EFIC Congress is trying to look at, in keeping with the theme of the Congress, which is personalised pain management, looking at targeted rehabilitation for pain conditions. We often hear a lot about targeted treatment approaches, particularly, say, for medication, but not so much for rehabilitation approaches. So we'll provide an evidence update in this area and then talk about what we see maybe the barriers and facilitators to having a more personalised rehabilitation approach in clinical practice.
Fantastic, fantastic. That sounds really interesting. That's something that's really, really important. And I think we all strive to try and achieve that. And I'm sure that the information that you'll give will be absolutely fantastic. So you've conducted numerous excellent clinical trials in the area of musculoskeletal pain. And recently you've also co-authored papers on N of 1 and single case experimental design studies. So what do you see as the key strengths and limitations of those methods?
Okay, so I think the criticisms of clinical trials have really been well discussed. So things like perhaps a lack of generalizability. The big one, the analysis usually produces a group effect. So there may be people that respond in there that we can't see or vice versa. We need a large number of patients and hence they're expensive. And from my experience in musculoskeletal pain, they take a long time to complete. So there's a long time to wait for an answer. And then you sort of change the question that you asked in the first place. So, but of course they have their strengths in terms of robustness and they're still probably currently the gold standard. We've started to dabble in single case experimental designs for the reasons I outlined above, that the funding required to do large trials. We thought, what are some of the questions we could answer with single case designs? They can take patient heterogeneity into account. And also I think the treatments can be more individualized, which is important for rehabilitation, where often that's what we do. We individualize the treatments more towards the presentation of the patient. And generally less patients are required. We've done a couple of these, really just trying to sort out what we could do in the area. And there are a couple of downsides, though. They're not as easy as what one would think, I guess. If you've got a series of cases and one person withdraws from the trial, it causes problems, perhaps more so than even an RCT, where we can use statistical methods around that. And the other area I'm particularly interested in is acute to chronic pain, so trying to prevent chronic pain in the acute stage. And SCEDs don't lend themselves so much to acute pain because they're not stable. So you usually need a stable condition if you're going to give the person one treatment following another. And with acute musculoskeletal pain, they're often on an improving trajectory, at least in that early phase. So it's difficult to conduct a SCED. It's like sort of conducting a SCED with a moving target a little bit.
Mm-hmm, mm-hmm. Fantastic stuff. That makes complete sense. So in the last sort of 5 to 10 years, what new discoveries and insights in the area of MSK pain have kind of excited you the most? If you could let us know.
Well, it's a tricky question, that one, isn't it? Because sometimes we feel like we're not moving very quickly forward. And so I tried to stick, when I thought about this question, stick to thinking about the clinical scenario more than, say, mechanistic studies and some of the discoveries using perhaps brain MRI and other markers and so forth. So I think one of the first things I think was important in MSK pain was to a lot of trials showing that what we would consider as standard, I guess, or accepted treatments, and rehabilitation was included in this, weren't particularly effective. So that was the first step. And then I think the next step was trying to get everyone on board to accept this. And rather than deny it, there was a lot of, oh, well, they didn't do the trial properly, they didn't have the right intervention. But there's so many trials out there now that there is some effect, but it's potentially, small, as we might talk about later. And I think this is still a huge challenge in the area, is to get everybody on board so we can sort of accept that and then move forward, although I think the tide is turning. The other thing I think is quite, I guess it's not that exciting, but interesting, and I think can make a difference, is the looking at early risk stratification of patients to see if we can identify those who recover this, identify those who may recover well and those who won't. It hasn't borne as much fruit as we'd like, and some studies show benefit and others don't. But I think it's a start, particularly clinically, to get clinicians to think in this way. And hopefully, with some refinements, we can, improve progress in this area. Mm-hmm. But lastly, I just wanted to talk about, I think we obviously need to understand a bit more about mechanisms underlying MSK pain so we can develop better treatments. And there's some of the data coming out from large cohorts that are studying multifactorial markers, physical and psychological markers from the time of injury until the recovery or the development of chronicity. And one in particular is the US Aurora study, led by Sam McLean in the US, recruiting people from the emergency department, a lot of people. And some of their findings so far showing perhaps that people with pre-existing vulnerability to stress might develop chronic pain. And there's studies from that group coming out all the time. So I think what they find will be really interesting. I'm looking forward to their results coming through, so that we can, a lot of cohort studies in this area, and ours included, we can recruit people from around 4 weeks. And there's a lot of things can happen in 0 to 4 weeks. So starting in the emergency department, I think, was a great idea, and taking a whole host of measures, we may be able to get some insights into, who and why some people develop chronic pain.
Mm-hmm, mm-hmm. Super interesting. And I think the information that you're going to be able to provide obviously goes, a long way towards that. And even, maybe get people thinking about that a little bit more is obviously certainly the first step. So far, sort of big effect sizes have been hard to achieve for chronic conditions. For example, chronic whiplash, low back pain, those sorts of conditions. And some people are sometimes rightly pessimistic about, progress in that area. So what do you think? Are you hopeful, and sort of how hopeful are you that we can, achieve optimal treatments for these conditions in whatever way you would consider optimal,
Yeah, that's a good question too. And I think we could look at it from a couple of angles. I mean, I think to expect large effect sizes in what we know about the heterogeneity of these conditions, and that a lot of the interventions have been sort of one-size-fits-all approaches, then probably in that, if we're thinking about those scenarios, that small effect size are probably good. There's something happening there. And perhaps we wouldn't expect large effect sizes, but moving forward, I'm not pessimistic about progress. It will be hard work. I think one thing that holds research back in this area is the funding dollars. It is more difficult to get funding for these conditions, which is sad, because they incur the most burden worldwide. And I think if we had more funding to get through the trials and get through, some of the mechanistic research, we'd really make some good insights. So maybe that will change as the burden of pain becomes more recognised amongst the policy makers and the ones who hold the money. But I think, if I look at it from my perspective, from whiplash research, we did a lot of early trials where we were very disappointed that there was no effect or small effect, if anything. And again, this comes back to treatments that we thought would be effective that weren't. But we are getting some hope now and getting some better treatments if we particularly recruit people in the early stage and then target risk factors, which I know risk factors aren't necessarily causal, but we are having some success in this area. And in one trial in particular where we targeted early post-traumatic stress symptoms using physios to do that they were trained by psychologists, we got a good effect for this area. And these were people at risk of poor recovery. The key to this seemed to be ensuring that the physios were adequately trained. And I think that's something that we need to think about. There's a lot of talk around, particularly in physiotherapy world, about psychologically informed physiotherapy, but I think we need to think about that a bit more, and it probably, has to increase our skills in that area to be more effective. So I think we're onto something there, but I think we've done another pilot targeting early central hyperexcitability or central sensitization, if you call it that, using medication. That was a pilot, shows promise. We have now got funding, I can be pleased to say, to conduct a full trial, so as of recently. So we'll see if that is effective or not. So I think if we're looking at, rather than trying to manage chronic pain, I try to look at it from the other end. What can we do in the early stages to prevent some people developing chronic pain? That's where I think the answers are going to be. And we know that patients, that don't recover well are more complex. They have more pronounced physical and psychological factors present that seem to impede recovery. So to be of benefit to those patients, we probably need to think about how we're going to skill clinicians to be able to do that.
Mm-hmm,
so that's a bit of a long-winded answer, but no, I'm not pessimistic. I think we're making some progress, but it could be enhanced with more research funding, I think.
The bottom line at the end, more research funding. Let's do that. Fantastic. That sounds really interesting. I think a lot of people will be on board with that, really being open to these psychological approaches and expanding physiotherapists' skill sets to be able to more importantly, confidently be able to address those issues, Sure. Amazing stuff. So just to round up everything that you've talked about, why should people attend your plenary session?
Well, I think I'm going to try and bring these thoughts and insights that we've discussed today together, and how we can provide more targeted rehabilitation, the current evidence and emerging evidence for that approach, and what we might need to do in the future for our health workforce to achieve this goal. I think that's going to be an important factor that's probably at the present time a barrier to, in my area of work, it's probably more in primary care rather than, say, multidisciplinary pain clinics. So looking at the patient with the acute injury who's managed in primary care and goes to a whole host of practitioners that could be involved, musculoskeletal practitioners. How can we sort of improve the delivery of healthcare in that early stage to be more effective and more targeted? So that's what I'll hope to talk about in Budapest in September.
That's it. Very, very good. Very good. Thank you so much for your time today. I really appreciate it. And hopefully that's instilled some excitement in everybody. It certainly has me. And I certainly look forward to seeing you in September.
Great. Thank you very much. I'm looking forward to it too.